Should be performed passively with the exception of the toes. All of the other components are exactly the same, and it's important, as always, to verbalize what you're looking at and what you're palpating. You don't have to verbalize what you're inspecting or palpating for. That's what that original statement still carries through to this portion of the examination. When you say in that first opening statement, this is what I'm looking for, you're done. You don't have to go, I'm inspecting the elbow for edema and symmetry, I'm inspecting the wrist for edema and symmetry, I'm inspecting for edema and symmetry. We don't want to hear it over and over again. One time is enough. Alright, so the patient is going to go from this position, stand up for me please. So they'll be done, they'll have done all their fingers and their thumbs, and go ahead and lie down for me please. And typically we want to examine from the right, always correct. Okay? We're going to start, I've already finished my inspection. I did my inspection at the beginning of the musculoskeletal examination, and I verbalized at the beginning of the musculoskeletal exam that I was looking at the alignment of the pelvis, and I was looking at the condition of the knees, and the posterior aspect of the legs, and the ankle, and the feet. I verbalized all that. So, that counts for your inspection, and I highly recommend you just get your inspection out of the way. If you want to do it joint by joint, be my guest, because you're going to inspect it anyway, again, as you're coming to it. So we're going to move straight into palpation. To begin palpation, I'm going to block the camera for a bit here, but you want to start at the upper border of the pelvis, palpating the ASIS, the anterior superior iliac spine. You want to come down and compress the pelvis and push down on the pelvis slightly. This checks the pelvic stability. I can palpate into the symphysis pubis. Then I want to come down and palpate the greater trochanter. And when people are looking for their greater trochanters, a lot of you are looking way up here. The head of your femur is right here. The greater trochanter is right here. Feel this bony knob on your hip right there. That's your greater trochanter. It's not up here on your hip. It's down here more on your leg, your thigh.
Will you, Professor Sugar, will you put your hands on the pubic symphysis area?
It's right.
I mean, I'm sorry.
Right there.
Sorry, really? I know. Okay.
If you feel down along the pelvic rim, you'll march right down to the symphysis pubis.
Okay, sorry.
Okay? So, symphysis pubis. Once you're done with the pelvic exam and you've felt the greater trochanters, come down and bring your hand in. You want to feel the back of the thigh as well as the front of the thigh. Come all the way down, squeezing moderately to evaluate for what we said we were evaluating for, and that's tenderness. Come down, feel the popliteal region. Come around and feel the femoral condyles. Come up over the top, palpate the patella. Come down the patella to the tibial tuberosity. I am going to take the tibial plateau off of the checklist because you cannot palpate the tibial plateau. I overlooked that when I was making my editorial changes this year. In order, this was my bone. This would be my tibial plateau. Unfortunately, I can't get my fingers inside her knee in order to palpate the tibial plateau. So I'm just going to take it off. What you are going to palpate are the joint margins. I'll worry about that in the winter when we get into the special knee examination. So right now I want you to concentrate on the femoral condyles, patella, patellar tendon, and tibial tuberosity. From there, continue down the leg, feeling the calf muscles all the way down, until you get to the medial and lateral malleolus, or malleoli, and feel the Achilles tendon come down over the calcaneus, up over the talus, and then you don't have to name all 7 bones in the foot. You can say I'm feeling over the remaining metatarsals, and then, feeling over many tarsal bones, and then out into the metatarsals. And for the foot, you can really do both at the same time, lateral and medial. Come down the first and the fifth, come in through the second and fourth, and then come down one last time on the third, all the way to the MTP joint. But you do have to palpate all 5. When you're doing the toes, same thing. You're going to either come from above or from below, but you palpate each of the phalanges separately along the lateral aspect. This is why, again, I recommend that you do this part separately. Do this part, then do the toes separately. After I'm done with the right foot, I can come around to this side, and yes, you can come around to the left side of the table. Perfectly okay. And I'm going to do the same thing. Come down. I'm going to go a little bit faster this time, feeling the epicondyles, feeling the patella, patellar tendon, tibial tuberosity, feeling the popliteal region, calf, tibia, medial and lateral malleolus, Achilles tendon, calcaneus, up over the talus and the remaining tarsal bones, and then the metatarsals and each of the phalanges and each of the interphalangeal joints. And that completes my palpation. Any questions on that? Next, we're going to start the range of motion examination, and I'll try and stay out of people's way as much as possible. The range of motion examination, we're going to start with flexion of the hip. I just want you to relax. I'm going to do all the work, okay? I'm going to flex the hip to roughly 90 degrees. Then, at this point, I can't, without really stretching the hamstrings, move it any further, so I'm going to incorporate flexion of the knee. So I'm fully flexing the knee. Now I'm going to fully flex the hip. Remember, this is a range of motion examination. Once I'm in this position, I'm going to come back up to 90 degrees, perpendicular at this point and in a straight line. I am then going to externally rotate the hip, making sure that I don't abduct it, so I should have paid closer attention. One more time. Notice the straight line here and here. I'm going to externally rotate the hip without moving this from its position. It's just rotating in its socket. Then I'm going to internally rotate the hip, doing exactly the same thing. Everybody see that? Yes, that is the correct way, because you're going in the opposite direction. When I go in this direction, my bone is rotating externally. When I do it in this direction, my bone is rotating internally. So just remember, opposite of the way the heel's going. Heel's going out, that's internal rotation. Heel's going in, that's external rotation. Make sense? Yep. Once I'm done with this, I am going to extend the knee and extend the hip. I am going to reach across to stabilize the opposite hip, and then I'm going to pretend it's Thanksgiving and I'm about to do the wishbone here, okay? I'm going to abduct the hip. There you go. Abduct the hip as far as it will go, stabilizing the opposite hip. You'll notice that I stepped back out of the way in order to facilitate this. Then I am going to carry it across the midline to adduct the hip. I'm going to do the same. Before I forget, I want you to roll up on your right side for me, please. Okay, head down. Stabilize the hip, and I'm going to extend this hip, keeping the knee straight. Do not bend the knee. Okay, the knee stays straight. I'm extending the hip. Okay, go ahead and roll back over on your back for me. And come across to this side. I'll do it one more time, a little bit quicker. I'm going to flex the hip. Now I'm going to flex the knee fully flex the hip. Come back. I'm going to externally rotate the hip, internally rotate the hip, fully extend the knee and the hip. I'm going to stabilize the opposite hip and abduct the thigh, adduct the thigh. Ask my patient to roll up on her left side. And again, stabilizing the hip, I'm going to extend the thigh. That's how that one goes.
Are you pulling against, or are you
Just
exerting pressure,
slight